Hello everybody, this is Noha Jastaniyah from Radiation Oncology at King Faisal Specialist Hospital and Research Center in Saudi Arabia. I am pleased to be presenting today at the SAA-RC Radiation Oncology Symposium, which is featuring an educational event and a planning challenge. I would also like to thank the organizing committee, including the Oncology Club from Bangladesh and the Radiation Knowledge Initiative, for giving me this opportunity. My talk today is on the current practice in radiation therapy for the treatment of cervical cancer. Given that we have a broad audience today, including medical physicists, radiation therapists, and radiation oncologists, I'll present the broad lines of radiotherapy in cervical cancer, with major references included for important details for daily clinical practice. I will also briefly highlight some of the challenges we continue to face in radiation therapy for this disease. Since the majority of the audience resides in Bangladesh, I wanted to educate myself about the status of cervical cancer in this dear country. Bangladesh is a highly populated area, with approximately 50% of its population being women. The population at risk for developing cervical cancer is approximately 50 million. The incidence is 10.6 per 100,000 women. As an example, in the year of 2018, about 8,000 new cases were diagnosed. The mortality rate is 7 per 100,000 women, and again, in the year of 2018, about 5,000 women died of cervical cancer. The gravity of the disease that it affects young women: 25% of patients dying from cervical cancer are in the reproductive age group. One of the roles of radiotherapy in cervical cancer is using it in the adjuvant setting. Patients with early disease, that is to say small tumors that are less than 4 cm in size and not extending beyond the cervix or upper vagina, are typically treated with surgery. Those patients with 2 or more intermediate risk features, such as lymphovascular space invasion, deep stromal invasion, or tumors exceeding 4 cm in final pathology, derive a progression-free survival benefit from adjuvant pelvic irradiation. Additionally, those who end up with high-risk features, such as nodal metastasis, parametrial involvement, or positive margins, benefit from adjuvant chemoradiotherapy with improvement in both progression-free survival and overall survival. The volume typically includes the pelvic lymph nodes, upper vagina, and parametria, and this is treated to a dose of 45 to 50 gray with conventional fractionation. For details on accurate delineation, I would like to draw your attention to the NRG recently published consensus guidelines in delineation of the clinical target volume in post-operative treatment of endometrial and cervical cancer, particularly when using intensity-modulated pelvic radiotherapy. The reference is shown here. Many data have shown that precise confirmation of the radiation using techniques such as EBRT or VMAT grant benefit in the treatment of pelvis in cervical cancer patients. Most recently, data from the randomized control trial from Tata Memorial Cancer Center in Mumbai were presented in ASCO annual meeting in 2020 after treating 300 patients randomized to either conformal radiation or EBRT, and with a median follow-up of 49 months, it showed significant improvement of late bowel toxicity, with grade 2 or higher bowel side effects dropping from 36% with 3D-CRT to 19% with EBRT at 4 years. These data reaffirm the use of EBRT or VMAT techniques when available as the new standard in pelvic radiotherapy for these patients. This is in agreement with many other retrospective series that have also shown drastic reduction in acute gastrointestinal toxicity. For example, grade 3 toxicity is reduced from 27 to 5%, and also reduction in late genitourinary toxicity that is typically shown to be reduced from 50% to 15% with IMRT. This is achieved while maintaining comparable disease control outcomes as a result of better dosimetric sparing of organs at risk. Additional benefits include the ability to boost grossly involved lymph nodes with the use of simultaneous integrated boost while maintaining the overall treatment time. Given these data, the use of IMRT and VMAT has become more popular and more widely accepted in the treatment of the pelvis and cervical cancer patients. Moving now to the more important role of radiotherapy in management of cervical cancer patients, which is treating those with locally advanced disease with a curative intent. Those patients with large tumors or tumors extending beyond the uterus or upper third of the vagina are primarily treated with chemoradiotherapy. The radiotherapy part involves using external beam radiotherapy to treat the primary tumor and a CTV to include the uterus parametria and regional lymph nodes using a risk-adapted approach. This phase allows reduction of the size of the tumor to a volume to which the dose is escalated using brachytherapy. External beam radiotherapy is given with concurrent weekly cisplatin as a radiosensitizer, and I would also like to draw your attention to the ICRU report number 89, which provides excellent details to the volume definition in the setting of both EBRT and brachytherapy, and also gives excellent details on the state-of-the-art dose reporting when using image-guided brachytherapy. Despite the reduction in toxicity with the use of IMRT in cervical cancer patients, there is significant variation in the rate of side effects that is reported in the literature with the use of IMRT, ranging between 10 to 85%. Such a wide range is thought to be attributed to the variation of the position of the target on a daily basis when delivering treatment over the course of 5 weeks. Yes, these techniques allow delivering conformal radiation. However, a large margin of error is accounted for in the radiation volume to ensure that the clinical target volume is included on a daily basis. This variation in the position of the target in pelvic malignancies is multifactorial. It's also unpredictable and is a result of many factors. As seen in the picture here, we can see the effect of bladder filling on the tumor target or the position of the uterus. This variation can also be the result of changes in rectal filling throughout the treatment, as well as normal variations in uterine position. Additionally, over the course of radiotherapy, significant tumor regression happens, and this results also in changes in the position of organs at risk, with, for example, small bowel falling into the clinical target volume. This picture is showing us an example of the effect of tumor regression as well as tumor deformation that can occur during the course of radiation therapy, with 80% reduction in the size of the tumor when comparing week 1 to week 5. And this carries the potential of underdoses of the target, as well as potential increase in the dose to organs at risk. The small bowel is shown in this example to fall into the clinical target volume. Based on the above data, any conformal treatment of the cervical cancer using IMRT or VMAT techniques would require routine daily soft tissue image guidance to verify target positioning. In fact, IMRT or VMAT cannot be delivered safely without daily soft tissue image guidance. Daily cone beam imaging allows identifying the problem. However, in most clinical settings, solutions are limited to improvement of target consistency, such as using rectal and bladder protocols, The use of large ITV margins, which can be aided by obtaining full and empty bladder scans. Replanning midway of the treatment to allow accounting for variation in tumor size and tumor topography, and also in some settings the use of plan of the day approach. It seems that the type of motion encountered in cervical cancer patients, as shown in the red boxes here, is complex and rapid and can be primarily managed by only online or real-time adaptive radiation therapy planning systems. Such online adaptive replanning will require a quick flow with online imaging, image registration, contouring, and plan reoptimization. Such online adaptive radiation therapy is limited as target definition remains mostly clinician-led and is also limited by the long dose calculation computational times. This is an area where MR Linac systems might be of use in the future. An optimal system will actually require real-time adaptive radiation therapy, providing advanced motion tracking using MRI guidance. The feasibility of MR Linacs continues to be evaluated in the setting of cervical cancer patients and will hopefully provide good solutions in the future. Moving on to the use of image-guided adaptive brachytherapy, which presents a major breakthrough in the treatment of cervical cancer patients in the last 10 years. This has allowed a switch from point-based prescriptions to volume-based prescriptions, facilitating dose escalation while respecting tolerance of ordinance at risk. Data from the ritual embrace as well as multiple institutional series show excellent local control of approximately 90%, excellent pelvic control, and overall survival with limited severe morbidity. This has led to wide acceptance of IGABT as a new standard in brachytherapy of cervical cancer patients. The overall results of EMBRACE-1 were presented in ESRO 2020, reporting the outcome on 1,400 patients with locally advanced cervical cancer using MRI-guided adaptive brachytherapy based on MRI obtained with applicator in situ and following the JIG ESRO recommendations. At a median follow-up of 51 months, the 5-year local control was 92% and the overall survival was 74%. This was associated with limited serious morbidity. These results compare favorably to the ritual embrace and present the new standard for patients with cervical cancer. Despite that brachytherapy can deliver really high doses to the residual tumor, the volume that can be treated is a function of the applicator type. Intracavitary brachytherapy with the addition of interstitial needles using different brachytherapy systems is being considered an alternative to intracavitary brachytherapy alone for managing large residual tumors and has been shown to provide improved local control. Owing to this advantage, the use of these systems is disseminating in the clinical setting worldwide. I will now move to highlight some of the evolving indications of SBRT in the treatment of cervical cancer patients. As shown previously, optimal augmentation of the parametrial dose is achieved with combined intracavitary and interstitial brachytherapy systems. However, they are not widely available. Very small studies have shown the feasibility of combining SBRT in addition to intracavitary brachytherapy on the same day by using the applicator as a guide. It remains a resource-intensive solution and long-term data are needed. SBRT also represents an excellent solution in treatment of recurrent disease. Take, for example, isolated para-aortic node recurrence, which is well characterized in 1.7 to 12% of patients with cervical cancer. Studies have shown that long-term control can be achieved with salvage chemoradiotherapy. SBRT represents a good solution to boost para-aortic disease to allow escalating the dose to gross lymph nodes, especially if close to dose-limiting structures. SBRT is also being widely accepted as an option for treating oligometastatic disease in cervical cancer patients. Potential for achieving cure can be seen in 10 to 15% of patients with isolated supraclavicular lymph node metastasis, and SBRT represents a good solution in these patients. Also, data from the Korean Radiation Oncology Group have shown good progression-free survival and overall survival outcomes with the use of SBRT, especially if achieving BED doses of more than 69 gray. Last but not least, radiotherapy has a well-established role in the palliative treatment of patients with cervical cancer. It can be used to relieve symptoms such as bleeding, pain, or vaginal discharge. The dose and fractionation is mostly dictated by physician preference and logistics at the treating centers. And an excellent review has actually highlighted how better studies are required to define the optimal dose and fractionation scheme for symptom palliation in these patients. It has examined the literature, and several studies have reported single or multiple monthly use of 10 gray doses for control of bleeding. There is limited data on the relief of symptoms such as pain or other symptoms, and toxicity is barely reported in these studies. So further analysis is required to establish what the best treatment dose and fractionation would be for these patients. So in summary, modulated radiation therapy techniques using IMRT or VMAT reduce early and late GI and GU toxicity while providing comparable disease control. However, large volumes of organs at risk are irradiated during external beam radiation therapy as a result of large amounts of target motion and unpredictable tumor regression and target deformation. Online or real-time adaptive radiation therapy systems are required to reduce the volume of irradiated normal tissue. However, these are complex and not yet widely available in a clinical setting. Image-guided adaptive brachytherapy represents a new standard in treating patients with cervical cancer, giving excellent disease control with limited severe toxicity. Irradiating large residual disease requires complex radiation therapy applicators with the use of intracavitary brachytherapy in addition to interstitial needles. SBRT role in treatment of cervical cancer continues to evolve. Radiotherapy has a well-established role in palliating symptoms in patients with cervical cancer. However, the optimal dose and fractionation scheme are yet to be well established. Thank you for listening.